because we're talking about regulating drugs and controlling supply and availability of different substances, I think this is a good point to talk a little bit about the opioid epidemic. We won't go into too great a detail, but we will talk about it. So, what has caused the opioid epidemic? Remember, this is largely a US phenomenon. We don't see this occurring in other countries. Well, through the 90s and early 2000s, we had a dramatic increase in the number of prescriptions for opioids. Whether it was all of them above, hydrocodone, oxycodone, there was this dramatic increase. So in the early 90s, there were about 75 million prescriptions for opioids in the US. By 2011, there were 219 million. Now, even accounting for population growth, this is a huge increase. The population of the United States did not triple or nearly triple in 20 years, but the number of prescriptions for the opioids did. So we had this dramatic rise in opioid prescriptions. And remember, this really only occurred in the United States. We're consuming most of the prescription drugs on the planet. In addition to this increase in prescriptions, what predated it slightly was advertising, was the marketing. So and they used really convincing taglines in their marketing campaigns. So this ad on the left from Vicodin, this is from the late 80s. Vicodin will free you from pain. Freedom from pain is a great tagline for a pain reliever. Now, whether these are directed at the consumers or the physicians, it doesn't really matter, because even if it's directed at the physician, this idea that this one drug will free you from pain can get transferred over the patient rather easily. This image over on the right, this is an OxyContin ad. 24 hours of pain control the easy way. One pill for every day rather than 2 or 3. So 24 hours of pain control the easy way. Again, very convincing taglines for these opioids occurring about when there was an increase in these prescription drugs. And if you overlay the number of prescriptions for opioids in the United States and the number of deaths due to opioids in the United States, whether they're the naturally occurring ones or the overall, there's a really strong correlation. As the number of scripts for opioids increased in the United States, the number of overdose deaths due to opioids increased in the United States. So there is an opioid epidemic. I am not even opening that question to debate. It's a fact. But what can we do to stop it? Well, we can actually introduce some abuse deterrent technologies into the pills themselves. So basically reformulating the pill that the opioid is delivered in to make it harder to abuse. So we could use different compounding agents, different other inactive ingredients that make it more difficult to extract the active ingredient, or we can actually change the formulation, change the compound to make it more difficult to extract the active ingredient. We can introduce essentially pepper spray into these pills, capsaicin, so that it would cause a very unpleasant burning sensation if you tried to crush and snort the tablet, which is what some individuals try to do. We can make these pills ridiculously hard, so that it's actually very difficult to crush the tablet, so it doesn't actually crush. Or when you try to crush, it doesn't turn into a powder. It turns into this kind of amorphous blob, so you actually can't snort it. And then we can actually introduce compounds such as niacin, which make it extremely uncomfortable if you take too many pills at once. So if you take too much niacin, it causes flushing, like redness and flushing, which is very unpleasant. You feel very hot. So we can introduce that into the pills themselves, so if someone takes too many, they'll feel these side effects and then again be deterred. So there are these abuse deterrent technologies that we can include in prescription opioids. But there's been some unintended consequence of introducing these technologies. Now, requiring or encouraging companies to develop these technologies comes at a cost. So opioids that include this type of technology, whether it's preventing people from crushing and snorting it, whether it's reformulating, whether it's including niacin, increases the cost of these drugs. So rather than getting a pill for say $40 or $50, now the pill is something like $70, $80, $90. And because people who are using these for illegal purposes, who are using these drugs to abuse them, they don't want to pay the higher rates. It's actually caused a lot of people to switch to heroin because heroin is relatively cheap. It does not cost 40, 50, 60, $70 to get a hit of heroin. It may only cost 10 or 20. So even during the opioid epidemic, some types of opioid use has decreased. So like Oxycontin use has actually decreased a little bit, but things like heroin have actually increased because people are switching from these prescription pharmaceuticals, which got them addicted to opioids, to heroin because it's cheaper to obtain. Now, ideally, abuse deterrent technologies is not necessarily a public health approach or the best public health approach to control the opioid epidemic because it's really more of a secondary prevention policy, right? People were already assuming that they're consuming the drug, which is a risk factor for for overdose and dependence. What we really want to do is actually change the prescribing habits of the physicians themselves so people aren't exposed to opioids to begin with. So the CDC has put out some prescription guidelines. They published them in 2016, and they're really quite common sense. So if someone has chronic pain, start with non-pharmacological therapies, start with non-opioid therapies. If you have to use opioids, use the lowest effective dose. Don't give the full-on dose right away. Use the lowest effective dose available. And if you are prescribing an opioid, have the physicians try to evaluate how likely someone is to become dependent, how likely they are to have an overdose. And if they have these risk factors for dependence, for overdose, try to mitigate that risk as much as possible. Another way we try to change opioid prescribing habits is through prescription drug monitoring programs, where when a physician is writing a script for an opioid, they can actually check to see if that individual, that patient, received any other scripts from other physicians around the state. Now, as of 2016, only Missouri did not have one of these systems, and within a state, they're very effective. The downside is that there's very few systems that talk across state borders. Now, large states, that's not really much of an issue, but for the small Northeast states, that's actually a big problem because it's relatively easy to go from one state to another and from one system to another in and shop different doctors to get the scripts without like hitting any triggers. So you really do need cross-state cooperation in order for these systems to be used effectively or most effectively.